Hey everyone, I'm Dr. Rishi. Today we will simplify one of the most confusing but high yield anatomical topics, the brachial plexus. In the next few minutes, we will break it down from roots to branches with a simple whiteboard drawing. No memorization, just logic. So we will start. The brachial plexus arises from root, then trunks, then division, then chords, and it divides into the branches. In root it has two rami. One is posterior rami and another is anterior rami. Anterior rami will be continue to form trunks. This posterior rami will be supplying the paraspinal muscles. So, which are the roots will be involving in the brachial plexus are anterior rami of C5 to T1. This C5 to T1 roots will supply the entire upper limb. Let's start from the spinal cord and move laterally. Okay, C5, C6, C7, C8, T1. These are the roots. Then it will form the trunk. Then it forms the division. Then cord, eventually nerves. The C5 and C6 root will combine to form upper trunk. C7 will be forming the middle trunk. C8 and T1 will be forming the lower trunk. It is upper trunk, middle trunk, and lower trunk. Then it has its own divisions. All the trunk will be having anterior and posterior division. Everything, all the trunks, upper, middle, lower, everyone is having upper, anterior and posterior divisions. Then we coming to the chords. In chords we have lateral cord, medial cord, then posterior cord. Lateral cord is formed by the upper trunk anterior division and middle trunk anterior division. It will form the lateral cord. Lower trunk anterior division alone will form the middle cord. Then all the posterior divisions of all the trunk will be forming the posterior cord. Then it will give rises to the individual nerves. What are the nerves? We have a mnemonic for that. A famous LML 4MU. That means 4M and U. For posterior cord we have another mnemonic called star. This is lateral pectoris nerve. This is musculocutaneous nerve. This is lateral root of median nerve. A median nerve has a two roots, lateral and median root. Lateral root will come from lateral cord, and medial root will come from medial cord. So this M is median root of median nerve. This M is median cutaneous nerve of forearm. This will supply the medial side of forearm. Sensory supply will be supplied from by this. Another is median cutaneous nerve of arm. And another M is that is a lateral cutaneous pectoris nerve. This is median pectoris nerve. U for ulnar nerve. Then S for subscapular nerve. Then N for thoracodorsal nerve, which will supply the latissimus dorsi muscle. A for axillary nerve. R for radial nerve. We can differentiate or we can localize this with lesion to a root, trunk or peripheral nerve with simple test by where C5, C6, C7 root will be forming a specific nerve, which is what is the nerve is long thoracic nerve, which will be supplying the serratus anterior. And from the root of the C5 a direct nerve arises. It is known as nerve to rhomboides. Then from upper trunk there will be a nerve arises which is known as suprascapular nerve, which will supply us both supraspinatus and infraspinatus. By checking these nerves, we will be localizing to the roots, trunks or peripheral nerves. In this video, we will be seeing the localization to roots and trunk alone. For localizing to the root, the check and the step 1 is always check for winging of scapula. Which will be presented in the long thoracic nerve weakness. So since long thoracic nerve arises from the root, if winging of scapula is present, we will be localizing the lesion to root. So now how to check the winging of scapula? Just ask the patient to stand facing the wall about 2 feet away, then instruct them to push firmly against the wall with both hands, like doing a wall push-up. Stand behind and observe both scapula. If you see the one scapula's medius border and the inferior angle protrudes like a wing, that's called scapular winging. This happens when the serratus anterior muscle is weak due to long thoracic nerve palsy. It may be caused by due to injury during chest tube insertion or mastectomy or due to another traumas also. So clinically we will placing the lesion towards the root. Secondly, we will be checking for step 2 is we will check for nerve to rhomboides. If this is weak, then we will be placing the lesion to root. Since nerve to rhomboides is also arises from the C5 root, so we will be placing the lesion at root. So how to check the rhomboides function? To test it, stand behind the patient and place your hand between their shoulder blades. Ask the patient to retract the shoulder, that is, pull their scapula backward and inward as if squeezing a pencil between them. Feel for the contraction of the rhomboid muscle under your hand. If there is no palpable contraction or asymmetry, it suggests a dorsal scapular nerve lesion which points against a C5 root lesion. Like this, you can make it a root lesion localization. From NCS, you can localize root lesion by paraspinal muscle denervation. This will also localize the lesion towards the root. Now root localization is over. Now we will be moved to trunk localization, upper trunk localization of suprascapular nerve. Using suprascapular nerve, we can localize to upper trunk. Suprascapular will supply two muscles, supraspinatus and infraspinatus. To check for supraspinatus, we will be ask the patient to start with their arm by side, then initiate abduction for the first 15 degree. If there is weakness or painful, suspect suprascapular nerve weakness and place the lesion in upper trunk. To test for infrascapular, flex the elbow to the 90 degree as you are going to defender in a boxer. Keep the arm abducted. Ask the patient to externally rotate the arm against the resistant. If there is weakness, then we will be localizing the infraspinatus weakness, and then the suprascapular nerve is weakened, and we will be localizing the lesion to upper trunk. By this, we can localize the lesion to root and trunk. In further session, we will be talking about more about nerves, mainly median nerve, axillary nerve, radial nerve, and ulnar nerve.